Hello, everyone. Welcome to another CP Solver's Virtual Morning Report. I'm very happy to be here with you all. Um, Today we have our friend, our teacher, Dr. Ravi, discussing the case presented by the amazing Simi, and on the whiteboard we have Minahil and Lara. Dr. Ravi, would you like to give some words today before starting?
Oh, sure. We are in April, the sort of
22nd.
the tail end of April now, 2025. Weather is amazing in Baltimore, so I'm on the East Coast, and it's like a delightful 60, sort of 60, 70 degrees Fahrenheit. So the weather has just made an amazing turn. It's kind of early for warm weather, but I'm enjoying it. But how about you? How about Minal? How are things? And then we'll ask Lara to mute as well.
It's like too hot over here in my country.
Oh, very hot. What's the temperature?
It's like 38 Celsius.
Oh yeah, that's very hot. That's very hot. How about you, Lara? How's life?
Hello everyone. I'm doing good, and that's the opposite type of weather here. It's quite cold. It's just around 8 degrees Celsius. Yeah.
Awesome, awesome. And again, appreciate you both of you for scribing and teaching points. And we have Sime who's going to present the case. How are you? How are things?
Hello, I'm very excited to present to my favorites, Dr. Ravi and Gaz, and just looking forward to the session.
Same here. Yeah, very excited. I really appreciate you putting this case together and bringing it. It's just absolutely fabulous, and you're becoming our favorite case presenter. So appreciate this very much. And we should start with the first aliquot and get the whiteboard launched. Thank you.
Can we start?
Yes, please.
So we have a 64-year-old female who presented to emergency department with abdominal pain and distension, and I'll stop here and would love to hear your thoughts.
Yes, what comes to your mind? I mean, this is very common. Abdominal pain is like one of the most common admissions to the hospital or presentations to the hospital. What's kind of going through your mind if you were in the emergency room seeing this patient?
Well, if I had an elderly patient with abdominal pain and distension with acute onset, and it was a lot of pain, the first thing I would do, like reflexively, would be discard an acute ischemic mesenteria, because that's the mesenteric ischemia. Sorry, I'm thinking in Spanish right now. So that's the first thing I will think. Any ischemic issues. I think that through the VMRs, we have learned that acute abdomen, or I mean, we still don't know the onset, but I'm assuming it's acute. It's quite difficult to pinpoint on like one thing. But the main issues are vascular, being the acute ischemia, as I mentioned, and obstruction. And those two would be like the main things. Of course, I would get like the point glucose like stat, see if there's hemodynamic instability, if there is any other like emergent issue like bleeding, or those were like the first steps getting this patient. And after I stabilize this patient, I would ask like, how much time has she been presenting this? How did it start? Did it have any trigger? Trying to find any trigger. What is the past medical history? Because of course, in elderly patients with, for example, diabetes, we can have gastroparesis. And then another thing that we have been that I always shout out to Parisa is like if they have constipation, because we can have translocation of bacteria and such. But I think now I'm rambling. So what do you think, Dr. Ravi?
Well, I think you just started off at a wonderful area or juncture in trying to ascertain what's going on with this patient. So not only do you have abdominal pain, and you could start very early in this diagnostic journey going through anatomical areas or organ base, liver, spleen, so on, but you also have abdominal distension. That's one of the sort of key facets I look for. So when somebody has abdominal pain, I'll think to myself, what's the blood pressure? What's the heart rate? What's the CBC? Is there white count? Is there distension? And when distension you put with the pain, you start thinking about all the different things you mentioned. And I will boil it down to its basics, which would be, is there air in the abdomen? Is there fluid in the abdomen? Is there blood in the abdomen? I had a patient that just dropped their blood count from 12 to 4, was put on an anticoagulation and hemorrhage into the abdomen. So blood could be in the abdomen too. Or with air, you mentioned ileus and so on, bowel distension. Could it also be stool? So, unfortunately, a large amount of patients do fool us. They'll come to the hospital with excruciating abdominal pain, and they haven't had a bowel movement for days. And they will swear that we're having bowel, they'll tell you, well, I have bowel movements daily, but all they're doing is taking a little bit of the stool and evacuating it, but there's still a long chain of stool within the bowel that needs to be evacuated. And it can cause excruciating abdominal pain and can lead to a lot of downstream effects like stercoral colitis, stercoral ulcer, and even perforation. So I would worry at this juncture, distension. What exactly is this distension? And a very, very good maneuver to do is maybe percuss the abdomen. If you hear dullness, it could be a signal that there's fluid in the abdomen. If it's sort of tympanic, it could be air-filled bowels, loops of bowel. And if there's shifting dullness, it could be ascites. So there are a couple of things you can ascertain from that as well. But sometimes abdominal distension, we reflexively sort of type 1, we think, oh, ascites, and you want to put a needle in it, but be very careful. You want to do an ultrasound, because I've been fooled many times. Patients with cirrhosis can have dilated loops of bowel, and you do not want to put a needle in there and maybe puncture a dilated loop of bowel. So at this point, I'm sort of early in this process. I want to generate a few hypotheses, but I do not want to go heavy into diagnosis because we still got a lot of cognitive legwork to do here with the next few aliquots. So I'll turn it over to Sime.
I love the thoughts, and I do have some more information for you. As for history of presenting illness, the patient mentioned that she had EGD for varices last month and developed abdominal swelling after the procedure, but had significant discomfort for the last week, and she presented today. She has diffuse abdominal discomfort with no focal area of pain, but it is also associated with decreased appetite. There are no aggravating or relieving factors. She also complains of dysuria and urinary frequency for 15 days. As for other systems, there is no bleeding, no melena, no fever, chills, nausea, or vomiting. And I'll stop here and would love to hear your thoughts.
So yes, there's a key feature here in the HPI, which really does, I think it's sort of what you would call, it's not going to pivot to the diagnosis, but is a pivotal point, which will shift your gear, your thoughts, or what do you call it, the gears in your analytical approach to this case towards a certain condition. What is sort of coming across your mind with this finding of the HPI?
The fact that she has variceal, and she already had EGD for it and then developed abdominal swelling makes me prioritize the liver. I would definitely love to see if this could be a decompensated cirrhosis, and therefore there was ascites. And one of this, when I combine diffuse abdominal pain with this abdominal distension, I would jump to see her vitals because I would like to avoid spontaneous bacterial peritonitis. By the way, shout out to Malet, one of my co-residents here in the chat, mentioned an SBP too. So I'm thinking the next thing I would definitely like to know if there are any signs of portal hypertension, if what's the state of the liver in this case to determine if it's perihepatic, hepatic, post-hepatic issue. And the urinary tract infection, I mean, I'm not gonna jump into it, but that's another thought when I listen to dysuria in urinary frequency. Although we have seen that to have a UTI, we have to have bacteriuria and symptoms. So another thing that I will include in my workup would be the UA and a urine culture. But those are like my reflexes after getting this piece of information.
Exactly. So the key feature I was sort of hinging on was this varices. Varices will sort of direct your mind towards possibly a cirrhotic complication, but you could have varices from just non-cirrhotic pulmonary portal hypertension as well. I'm thinking pulmonary hypertension because I had a patient with pulmonary hypertension, but portal hypertension due to a non-cirrhotic cause here. So you want to look for maybe on your exam other features of cirrhosis. So you are going to look for examination findings like AVMs. You're going to look for caput medusae. You want to look for findings in the hand. There's like several findings that you can have in the hand for cirrhosis. Maybe you could also have hyperbilirubinemia. Check the sclera as well. And with this abdominal pain, I think somebody had put in the chat SBP. Molly had put is a very grave, something that you need to diagnose and be concerned with. So you want to at least do the intervention, do a paracentesis and look for PMNs in the fluid. So are we dealing with a case of SBP here? The patient kind of would have septic findings as well, I would wonder. So I want to look at the temperature, look at the white count. But, you know, patients with cirrhosis don't always register with these findings because they are sort of in an immunocompromised state, so they may not have a white count elevation and so on. So you still have to have a high index of suspicion and do the paracentesis and look for PMNs to make that diagnosis here. I did have an interesting case though recently with a patient with minimal ascites but having septic features, and even with minimal ascites having septic features, cirrhosis, you could manage or present with SBP in these patients, and you also have to think about the abdominal pain as part of that presentation as well. But here, I think, yeah, definitely cirrhosis is something that is of interest, and I would look for a cause. If this patient doesn't have in the past medical, we haven't even gone to the past medical history, but if there's no diagnosis of cirrhosis in the patient, we do want to look for something in the history like hepatitis and so on. Could this be fatty liver disease manifesting with the new designation of this would be metabolic associated fatty liver disease. So we would look for signatures of causes of cirrhosis, but there may not even be cirrhosis here. So we'll get to the next aliquot. Back to Seema.
Amazing thoughts. So the patient has a past medical history of hypertension, type 2 diabetes, hyperlipidemia, anxiety, esophageal varices, and gastric ulcers, as well as recurrent UTIs. The medications include insulin, pantoprazole, carvedilol, metformin, and empagliflozin. As for the past surgical history, she got laparoscopic cholecystectomy done in 2020. And as for family history, she has uterine carcinoma in the mother. And patient does not use drugs, no smoking history, but has a history of 20 to 30 beers a month and is allergic to penicillin. And I also have vitals and some exam findings for you. The patient was afebrile. Pulse was 140/70. BP was 140/70, pulse was 82, respiratory rate of 17, and the patient had a BMI of 30. As for the exam finding, patient was awake, alert, not in distress. Lungs were clear to auscultation. As for cardiac examination, there was normal rate, no murmurs, no JVD. In abdominal examination, the abdomen was distended, slightly tender in all quadrants. And we also found multiple spider angiomas on upper chest. However, there was no asterixis, no tremor, and we had mild bilateral leg edema. However, there were no skin bruises, and I'll just stop here.
So we have the exam, yes, and does this exam move the needle forward for you? Can you make progress with this case, you think?
Now I am more than interested in seeing what is going on with that liver. I'm trying to, because I mean, we see that she's already distended, slightly tender, diffusely abdomen. And she also has bilateral edema. So I'm thinking, could this be also like anasarca? And the main things when I see that there is a diffuse edema is look at issues in kidney, liver, lungs, and heart. And in this case, I would prioritize liver. So she's hemodynamically stable, but that doesn't mean that this cannot get ugly quickly. So the first thing I would do is first of all see if this patient I would definitely like to know a ICBC, their metabolic panel, her hemoglobin, glycosylated hemoglobin. I'm really interested on her UA and urine culture to see again. I'm not like taking my finger off this probable UTI, and definitely look at the serum lipase and amylase to see if their like pancreas could be involved, although it's not very probable in my books. But I'm really trying to find like also the onset, like because at this point she has spider angiomata and this swelling. So I'm really prioritizing looking at the liver.
Absolutely. So as we like to say, yeah, the center of gravity here is the liver, but then what's interesting is there's two facets to this case, which are intriguing. And the history, definitely looking into the history, pays dividends in trying to solve the case or solve the cause of this liver dysfunction that we've already established. So one is there's the alcohol use disorder. So heavy use can actually result in liver cirrhosis. Probably three features of this case, actually. The second is with hypertension, diabetes, hyperlipidemia, all these metabolic associated conditions. Could this patient have metabolic associated liver dysfunction, liver disease? So what we call MASLD, about a third, I guess, third, maybe half, may actually progress to liver cirrhosis. And then there's this other history or family history of uterine cancer in the family. And as we all know on CPS cases, it's never clear the competing or what's really running or we thinking is in contention for the diagnosis is not necessarily the cause. We may have to switch gears and look at other features like malignancy here. So there's metabolic, there's sort of substance use associated liver disease or dysfunction, and there could also be malignancy. Now, how could malignancy manifest with this? Well, you can get the abdominal distension. Are there two sort of diagnoses that are competing here? Yes, you could have the metabolic and also the alcohol associated effects or downstream effects on the liver, but then you have this uterine cancer. So if we look at inherited traits or inherited malignancies that run in family, you can have gynecologic conditions that can run in families. And we definitely would have to look at this and see if this patient has had any sort of age appropriate screening for cervical cancer. Has this patient had any dysfunctional uterine bleeding? Has this patient had any recent workup, maybe fibroids or anything like that they've had menorrhagia or any presentation like that? Nothing's been disclosed yet in the HPI at this case, but maybe this could be a development. So I would kind of keep sort of playing the twister game, both hands in sort of the cirrhosis, alcohol, metabolic disease, but also one foot on the possible malignancy as well. What do you think, Yaz?
Oh yeah, definitely. I'm wondering like if asking for a GGT would also be, or a blood alcohol level would be correct in this case after reading the 20 to 30 beers per month to see like how her consumption behaviors have been as of later.
Oh, that's a wonderful thought. As you begin to manage such patients with multiple different issues, identifying a potential concern for withdrawal, I think is just an incredible anticipation of possible downstream problems. Why? Because if you are busy trying to solve the case and trying to manage all the different issues, and you miss that, such patients may actually go through devastatingly painful withdrawals. And what happens is they may leave against medical advice. And again, that's doing a disservice to the patient. So you just struck a very important concept there. Any substance use disorder, any alcohol use disorder, treat for any potential withdrawals or downstream withdrawals because you may lose this patient to leaving against medical advice. So excellent from the amount of alcohol use that the patient is explaining to you. I think definitely making sure having the patient on a protocol for alcohol withdrawal is a major concern, and also then giving them supplements to also help in that case as well, because they'll be nutritionally depleted as well. Excellent thought there, yes. All right, and regarding your GDT, so yeah, what would you do in this case? What would you order if you, again, were in the emergency room to sort of move the needle forward in deciphering what's going on?
Well, after the normal package of like CBC, CMP, her UA, the urine culture, and abdomen ultrasound, I would ask also for coag, because if I'm prioritizing liver, I have to see her coagulation time. Lipase and amylase, maybe, because I mean, I would definitely want to rule out any other issues. Again, the blood alcohol level, because even if this patient is not an AMS or does not show any, is not in apparent distress, my spidey senses tells me that this is the kind of case that might look stable but can get ugly very fast. And pelvic ultrasound as well. I would leave the CA 105 and all those tumor markers for later if I don't find anything conclusive. But that will be like the first things I would do, and definitely to see a viral panel. I like that thought, Sam, in the chat. But that would be like the first thing I would like to get.
Absolutely wonderful. Yeah, I agree with all the tests that you've mentioned. I think it's important to start the process. What will help you to make progress in trying to treat? What are you treating here? We don't know yet, but these tests will disclose maybe an infection, maybe the etiology of the liver disorder, maybe there's SBP. I doubt at this juncture hepatic encephalopathy. The patient doesn't have hysterexis and altered mental status. You know what? So what I've always sort of learned also, and I kind of jumped the gun before even working up liver injury, cirrhosis, and so on, is I question myself: is this patient going through the throes of acute liver failure? Why? At that juncture, if you have diagnosed acute liver failure, you must get this patient to a transplant center and not waste time, because this can be a very slippery slope, but that could lead to the patient passing away. So how do we define acute liver failure? It's a patient with encephalopathy, altered mental status, abnormal coagulation factors, and I think the time duration is within 26 weeks. So if there's anything else, jump in, correct me, but I remember acute liver failure from these three features, and I will sort of do the mental process: acute liver failure or not. If the patient isn't meeting this criteria, then I will move through the rest of the workup to sort of determine what's going on with the patient. Any other thoughts, Yaz, before we go to the next slide?
No, I'm just wondering what's the next piece of information. It's really nice.
Yeah, I think, yeah, the ultrasound image, you know, it's also always sort of a toss up. CT is very easy to get. CT, ultrasound very easy, even POCUS. See if there's ascites, we will at least try and do a paracentesis to see what is there. Is there SBP that is in process? And a CT to look for other features. We haven't even established image-wise if there's cirrhosis. Now, many a times, I think we've had this on VMR. Ravi had mentioned there was a case where a CT may give you a false positive of cirrhosis. So what would be a better way of determining liver cirrhosis would be a biopsy. But nowadays we do these fibrotic indices, so doing a FIB4, doing a scan to determine how pliable or how thick fibrotic the liver is, can avoid. And actually we have been doing less and less biopsies to determine liver cirrhosis. So back to you, Seema.
I loved how you thought about liver, but also very broad diagnosis at this point. And so we did EKG and echo, which were normal, and ED staff attempted paracentesis, but they were unable to find a suitable pocket of fluid. Urine analysis was consistent with infection with E. coli, and nitrofurantoin was started. And I also have some labs for you. Hepatitis panel was negative. WBCs, RBCs, platelets were within the normal range. PT was elevated at 16, but PTT and platelets, they were normal. Electrolytes were within the normal range except glucose, which was elevated at 133. Calcium was low at 8.3, and albumin was low at 3.2. AST was 65, which was elevated. Total bilirubin was normal, but direct bilirubin was 0.4, which was elevated, and alkaline phosphatase was also elevated. And I'll stop here and would love to hear your thoughts. Also, milase level was checked. That was also normal, as you guys asked.
So intriguing labs. Anything jump to your mind, Yaz, from some of these laboratory markers?
Well, I'm glad to see that there was also like a coag here, like a coag panel. And I said that the PT is the only one elevated. So I'm thinking more of like factor 7, all that stuff. But maybe that's because of the difficulties of the liver, like they're synthesizing proteins and such. Glucose is a little bit high. I would have, honestly, I had expected a lot more glucose here. Again, low calcium, which makes me think, where is it going? Again, just as a thought that might just be in the back of my mind is like, if there is low calcium, I would definitely like to look at the pancreas, because whenever there is pancreatitis, there is this like pathophysiology of like saponification and whatnot, and there's where the calcium gets low because it gets like consumption, something like that. So I would definitely like to like ask next for amylase and lipase, if possible. And I mean, CBC is normal, viral panel is normal. I'm also like thinking, okay, this patient, a very great thought in the chat is that this patient is an empagliflozin and she has a UTI with E. coli. And we know that whenever our patients are on glucosuric agents, bacteria love that. So that causes a higher rate of UTIs. I'm really puzzled to see like this somewhat. I was expecting a mess on the labs, honestly. So I think I am hitting a wall.
Oh, and it's a incredible wall that you have hit, because there's just so much here. And I think the learning is tremendous, but what you've able to ascertain from this case is just next level. I think you're just doing a superb job. And you're able to brainstorm and think about a certain number of things with such a case. And definitely is a difficult case, and trying to decipher this within the scope of an hour, it's a difficult task, because usually this all plays out over days to weeks, trying to figure out what's going on. But with the labs here, the first thing I kind of want to roll it back to the alcohol. And on scan, I just want to ask you, there was no liver cirrhosis that was mentioned, and no hallmarks like with alcohol. How can alcohol cause any injury to the liver? You can get hepatic enlargement, so you can get hepatic steatosis, steatohepatitis, and also fibrosis, cirrhosis. So alcohol will injure the liver in one of these ways. So when you have steatosis, you can have a massive liver. I had one patient I cannot forget. I have the CT scan where the liver went from the right side all the way to the left side, and it took up the entire abdomen, and it was a very protuberant and swollen abdomen, and it was all due to hepatomegaly. So was there any abnormal finding with the liver on the imaging?
Dr. Ravi, I haven't mentioned the imaging yet. I left
Oh,
it for next
okay.
telepod. Do you want me to mention it now?
I think the ultrasound, you said they weren't able to find a pocket of fluid.
Dr. Ravi, ultrasound was not done. They tried
Oh, okay.
paracentesis in the ED, but they couldn't find it.
Okay, I was mistaken because I assumed you're doing ultrasound guided paracentesis, but this was a blind paracentesis. Okay, so they weren't able to find an area to get fluid from. Okay, so that also is troubling. We were thinking abdominal distension. There's no fluid that they could easily obtain. So when you have a large distended abdomen, if it is ascites, you just put the needle into the lower quadrant, and you will get a lot of fluid if there is quite a bit of fluid in there. But then you have to switch gears. Remember when we started out initially thinking what's causing this distension? Fluid is kind of out of there. Blood is kind of out of there as well. What else can you have? You can have stool. You could have mass or a malignancy, liver, like I mentioned, steatohepatitis, stool, blood, liver, air, if it's distended, bowels. And that's where you have to be very careful. And I always recommend do a ultrasound, because distended lucid bowel could look like an ascitic abdomen. The other thing is here, what's really troubling me, Yaz, is the platelets. When you have, from the get-go, we've kind of decided this is cirrhosis and there's chronic liver disease, and the patient has likely features of liver disease. We have the angiomas and so on. But, usually I see, I don't know how commonly associated thrombocytopenia is, but it is very much associated, because as erythropoietin is made in the liver, in the kidney, thrombopoietin is made in the liver. And when you have liver cirrhosis, you do not make thrombopoietin. The platelets will decrease in quantity. But here we have normal platelets. So either we're early in the process, or platelets can be acute phase reactant. Maybe they're normal because of something else that's going on. So can we sort of make a compelling argument for no cirrhosis or no chronic liver disease from this? Probably not, but you know what? Normal platelets kind of does make it less likely. The coag's a little, the PT being a little high there, the AST, ALT, but when you look at the pattern of liver chemistries, ALP being larger or higher in proportion to AST and ALT can mean one of a couple of things. One is there's infiltrating disorders or infiltrating mass, like metastases, maybe like granulomatous disease into the liver. If the ALP is elevated, it could be cholestatic sort of disease. So cholestasis, and the direct bilirubin is high. So maybe there is an element of cholestatic liver disease here. But imaging is key here, because we have floated the hypothesis of infiltration into the liver, and what could infiltrate malignancy. And from the family history, this uterine carcinoma is of interest to me. And so definitely I would go with the imaging that CMA has for us in the next aliquot. Before we get to that, anything else you asked before?
No, I'm learning so much. And I distinctly remember having like 2 VMRs where like signet cell carcinoma causing ascites in an elderly woman. I mean, I think it has only happened twice, but the fact that it already happened, it's very interesting. So I'm also keeping that in the back of my mind. But yes, Amy, like, let's see what more information you have.
Amazing discussion, and we were also concerned about ascites like you were, and so we got the right upper quadrant ultrasound, and interventional radiology was consulted, and 800 cc of fluid was removed, and there was presence of ascitic fluid. Ascitic fluid analysis showed cloudy fluid. It was high-sag ascites, and ascitic fluid albumin was low. And I'll stop here and would love to hear your thoughts.
So there was fluid there, and now we have an albumin. What do you think at this point, Yaz?
Now, for this patient, for cloudy fluid and a high SAT, I would be prioritizing still I would do a cytology and to see if there are bacteria also, because I'm not taking my finger off a spontaneous bacterial peritonitis. I'm really thinking also, like, what if this could be a hepatorenal syndrome? So I would also look for like creatinine and BUN. So those are the first things I'm really thinking at this point. Something with high SAH, I would think it is, again, correct me if I'm wrong, is transitive. So this high SAH showing transitate, and this spider angiomas, for me, I'm also thinking vascularity, like portal hypertension could be one of our main causes. But now I'm really puzzled by this cloudiness again. Those are the two things I would love to like dig a little bit more in. Like, there are no infections, not because I'm biased, and portal hypertension.
So great thought there. I think you focused in on two features there. One, the SAG, the high SAG. So what do you do with this? And number two is this cloudiness. Does cloudiness always directly correlate with infection, malignancy? I would say not always. Just like at the bedside, you may see cloudy urine. It could be in a catheter. It could be due to many different things. It may not indicate infection. We don't establish infection due to that, but it does raise my antennas. Could this be like early on we had hypothesized or you had hypothesized SPP as a possible cause of abdominal pain? Although we don't have features of infection, no fever, the white count. But again, if patient has liver cirrhosis, they are immunocompromised, so they may not manifest with the typical laboratory features. Maybe not even have a fever, but they have the abdominal pain. So that is one thing. High SAG here, we are dealing with portal hypertension due to a cirrhotic etiology, and you would kind of go through the motions. There is a nice schema on CPS where it goes through prehepatic, intrahepatic, posthepatic, and which one of those are possibly the cause. We have definitely risk factors for liver cirrhosis, one which is likely the alcohol use disorder. But again, I'm kind of worried with this uterine carcinoma. And if you look at the imaging, there's this echogenicity, and I'm trying to understand. I don't have a sort of a script for increased echogenicity. Is it echogenicity meaning liver cirrhosis? Is there nodularity? We're not seeing that, but that would indicate maybe cirrhosis as well. But I'm interested in echogenicity. Is it indicative of a mass in the liver as well causing this? And that could lead to cirrhosis, ascites that we are seeing here. But again, maybe there's two processes at play here. So I like to see what the fluid, at least look for PMNs in the fluid. I didn't see what the polymorphonuclear cell count was, and if we need to start treatment with antibiotics at this point. Any other thoughts, Yaz, before we turn it over to Sime?
So for now that you mentioned echogenicity, and I completely agree, I would like to see if there's nodularity, of it's just one single mass. Again, very in the back of my head, the fact that this patient has a family history of uterine carcinoma, I would definitely love if it's like multiple, think of metastasis. And if it's there are sclerosis changes, of course, I think that's seen with biopsy, if I'm not wrong. Also thinking, well, if there is something in this and it's not a mass, it's not a sclerosis, if there could be any granulomas or granulomatous changes that can be caused by, like, I don't know, sarcoidosis and stuff like that. So, I mean, now I think I'm like really rambling, but the fact that there is echogenicity. I also agree that we have to see what is causing it. Yeah, very interesting to me.
I loved the thoughts, and we checked for SPP. There was no evidence of PMNs here, and we got CT abdomen and pelvis, and there was cirrhotic morphology of liver with enlarged main portal vein. And also we found the previous biopsy report, just like Dr. Ravi mentioned, it did show focal steatosis. So we were also concerned about fatty liver disease in this patient, and we were not sure what the trigger was for cirrhosis, and I would love to hear your thoughts here.
So you want to start? Yes. Interesting imaging.
Yeah, very, very interesting to see that there is this focal steatosis. I mean, this patient does have hypertension, hyperlipidemia, type 2 diabetes. We don't know if she had access to a also like great thought animal, high BMI. We don't know if this patient had an access to what kind of access to food they had. So there is this NASH that can cause cirrhosis, like fatty liver disease causing cirrhosis. I mean, again, this patient, she has a high beer consumption, but I also think that it's important to not anchor on this kinds of like social and health related behaviors and also like dig over that. I'm thinking that what else can cause cirrhosis aside from fatty liver disease, aside from alcohol, um, other medications and environmental exposures. But yeah, I'm really wondering if there is anything else that I'm missing on the causes of cirrhosis. And yeah, like I see there's an enlarged main portal vein, thinking, well, could this then be a vascular issue, vascular malignancies, or yeah, like there are so many like differential diagnoses that I think that I should work in my program presentation to like focus on one. What do you think, Dr. Ravi?
Wonderful thought there. Yeah, I'm also having, so I guess I don't think we had trouble trying to figure out, okay, there looks like features and hallmark of liver cirrhosis, but then the cause, I'm definitely interested. What is the cause? And as you mentioned, NASH, the technical term, I kind of grew up with the term NASH, but now has changed to MASH and MAFLD. NAFLD becomes MAFLD. So MAFLD is the metabolic component without inflammation, so fatty liver. The fatty liver, I think like a third of patients with that can develop inflammation, and you end up having the MAFLD, and that can lead to cirrhosis. So there definitely is the metabolic component, and then the use of alcohol didn't help matters. The interesting layer here that we kind of put and maybe we amplified was the uterine carcinoma. But if it was a malignancy, if you think about it, it would have been a low SAG causing ascites. But a lot of people had hypothesized in the chat, and I was right on board with all the different kind of conditions that could migrate to the liver and cause issues like ovarian cancer, lung cancer, and so on. Breast cancer can cause ascites, but that would be non-portal hypertension variant. This was a high SAC. This was cirrhosis causing high SAC, causing ascites, and then what we have to do is then determine, yes, this patient is having decompensated liver cirrhosis. So you can be in a compensated state, not have the liver enzyme elevated, not have the pain, not have the ascites, be managed on appropriate medications. But then when you decompensate, something will trigger that, maybe continued injury through alcohol use, maybe substances, maybe taking too much of maybe herbal medication. You always have to ask a patient if they're taking anything that could disturb the equilibrium and move you into a decompensated state. And what are the features of decompensation? Hepatic encephalopathy, esophageal varices and bleeding, abdominal ascites, and so on, anasarca, and so on. So these would be features of a patient having, you also mentioned hepatorenal syndrome. That would also be a feature of decompensation with a patient with liver cirrhosis. So the objective here would be to then bring the patient back to compensation. And would this patient meet criteria for liver transplant? So get them acquainted with a liver transplant program. They would have to abstain from alcohol use for a certain amount of time. In between them, put them on medications that would help at least with the varices. You already had esophageal varices before, so putting on a beta blocker, diuretic, and so on would be helpful. And then having them follow up with a liver cirrhosis specialist would be key at this point. Any other thoughts? Yes.
No, absolutely. I'm really enjoying this because at this point, like, as I think that we should focus on where did the cirrhosis came from. Again, it could be alcohol, yes, but there are many other things that can cause cirrhosis. I think somebody mentioned in the chat genetic conditions, hemochromatosis, Wilson's, autoimmune conditions like the autoimmune hepatitis, PPC and PSC. Those kinds of things can also cause cirrhosis. In this case, like we do have other things that predispose this patient to other etiologies, but it's interesting to review all of the different causes. Back to you.
The one thing I also forgot to mention is there a risk for hepatocellular carcinoma, so you would have to have routine screening with a abdominal ultrasound every year to determine if there's risk of growth for HCC in such patients. All right, back to you, Sime. What did you learn from this case?
I first want to thank Alec for sharing this case with me, and I loved the discussion. And I learned that we were not sure of the trigger, what the trigger was for cirrhosis in this patient. And as you mentioned, platelets were normal. They might be normal because patient came with infection with the E. coli and was having dysuria, so cystitis might have caused elevated platelets as acute phase reactant. And for decompensated liver cirrhosis, like you mentioned, we can make the diagnosis when we have evidence of elevated portal hypertension, as is evident by ascites in this case. And synthetic function of liver is also affected, as we had an elevated PT here and albumin level was also low. So that helped us make the diagnosis, but we are still not sure of the trigger, whether it be alcohol or fatty diet or a combination of both.
Yeah, I think that's a valid point with this urinary tract infection. We always mentioned, we had this last week, AMK was on, very valid point about a patient having symptoms, you should treat if they have an abnormal UA and have symptoms. But this patient, when you have immunocompromised state, it's a little tricky. But you would have to, I know she had a dysuria and increased frequency, so that helps. So definitely treating a UTI in this case would be beneficial. And this could be, like you mentioned, it probably flipped the switch to decompensate. And you can have many some kind of decompensations from urinary tract infection. You could have the abnormal mental state. You could have arrhythmias. The body just moves out of compensated to a decompensated state. CHF, if patients pre-existing CHF, they can be pushed into decompensated heart failure. So here, it could have flipped the switch on liver cirrhosis into a decompensated state with the additional burden of the alcohol use disorder and so on. Excellent case. Thank you. So well presented. I appreciate you bringing us such a rich case. I definitely will be reading liver cirrhosis today and relearning all these concepts. I appreciate it very much. And I guess we'll turn it over to Lyra for the teaching points. Thank you.
Thank you, Simi, for this amazing case. And thank you, Dr. Ravi and Yas, for this amazing discussion. It was really rich in teaching points. And it all started with initial approach to a patient that presented with abdominal pain as well as abdominal distension. And we learned that when we see the patient with abdominal pain, we really need to firstly prioritize the management and firstly assess the patient's hemodynamic stability, and also make sure to rule out especially life-threatening causes that are often missed. For example, acute mesenteric ischemia and intestinal obstruction. And for abdominal pain, we have our anatomical approach. But when we combine this with abdominal distension that has more narrow differential diagnosis, we think about what's causing the abdominal distension. It can be air. It also can be free fluid in the abdomen. Especially, we need to think about blood and watch the progression of the patient's CBC. We can also think about some solid causes of abdominal distension like masses, or in elderly patients, we can forget about a possibility of constipation and stool accumulation that also can cause abdominal distension. And the simple test that can help us differentiate between these three causes would be the abdominal percussion. And also abdominal ultrasound can really help us here. And we also need to investigate the patient history to understand any comorbidities like diabetes mellitus or history of prolonged constipation. And in this patient, in terms of history, we learned that she has a history of esophageal varices as well as bleeding associated with this condition. So we started thinking right away about possibility of portal hypertension diagnosis in this patient. And the next question that we were facing with, what is the cause of portal hypertension in this patient? Is it cirrhotic or non-cirrhotic portal hypertension? And to understand the etiology, the exam would be really helpful here to look for stigmata of cirrhosis, like spider angiomata in this patient. And also understanding the possible etiology of portal hypertension can help us understand the possible etiology of abdominal distension in this patient, which had a higher chance of being ascites in this case. And when we have a patient with ascites, we really need to keep in mind the possibility of spontaneous bacterial peritonitis. Next, we were trying to understand the center of gravity in this case, and we were facing with basically anasarca in this patient. And when we're talking about the peripheral edema, the target organs that we need to keep an eye on would be the kidneys, the heart, and the liver, which was likely the problem here. But this is not the end of the story. And when we're talking about the liver, we need to understand the cause, what caused the liver to decompensate. And based on the history in this patient, we were talking about the three main possibilities, which would be alcohol use disorder. And especially when we have such complicated history, we need to keep an eye not only on the liver function, but also on the possibility of withdrawal developing. And we need to manage that as well. The next option was muscle D, and the interesting part is that 1/3 of a patient progresses to cirrhosis. And the third option was malignancy. And for this, we need to consider not only the primary liver malignancies, but also distant malignancies that can cause ascites, and especially the malignancies, which can mimic ascites and mimic liver ascites and cause primary ascites as well. And we also need to rule out acute liver failure, because this will change the management for the patient. And for this, we need to obtain a set of labs, which is liver function test as well as INR. And also we need to check the patient for altered renal status. The next thing that we need to rule out is pseudocirrhosis, which basically is a mimicry cirrhosis on imaging. And for ruling in the diagnosis of true cirrhosis, we can use fibrosis index or the gold standard, which is biopsy. Then we talked about the possibility of liver injury patterns in this patient, and we were entertaining the possibility of alcohol use disorder. And for this, we remember the typical progression for this patient, which is steatosis, steatohepatitis, then progressive fibrosis with the endpoint of cirrhosis. And the labs pattern also was interesting in this patient, with more prominent increase in alkaline phosphatase compared to AST and ALT, which can be seen in things like liver infiltration or cholestatic patterns. We also talked about the really high yield topic, which is acidic fluid interpretation. And in this patient, we were facing with the high SAC, which means that we're dealing with true portal hypertension here. And also we talked about the cloudy appearance of the fluid, which can at the early stage clue us into the possibility of infection and spontaneous bacterial peritonitis. And even with normal white blood cell count, we can still think about this diagnosis because we can catch the infection early when there is not enough accumulation of white blood cells in the acidic fluid. And also the patient could be immunocompromised and not have enough cells to for us to see. And the last point is we talked about decompensated cirrhosis, which was the final diagnosis in this patient. And when talking about decompensated cirrhosis, we need to look out for features of decompensation, which is worsening ascites, worsening hepatic encephalopathy, variceal bleeding, or lab patterns that can indicate worsening synthetic liver function, especially INR. And we need to remember that this is not an endpoint diagnosis, and we always need to understand the cause of liver cirrhosis decompensation. And the target of our treatment would be the removal of this trigger after identification, compensation of this patient liver function, and also entertaining the possibility of liver transplant. And this is it for my teaching points. Thank you again for this amazing discussion.
Awesome, Lara. Thank you so much for the teaching points. Thank you, Minahil, for describing, and thank you all for being here today. We will see you tomorrow evening with Charmin and Alec, and for a nephrology VMR with Dr. Snyder. So take care and have a great rest of your day.
Thank you, Lyria.
Bye-bye.
Great job. Bye.